Hi everybody, I'm going to do your lecture about shoulders online today. So the next joint we're going to talk about is the shoulder joint. Now the shoulder joint compared to the knee and compared to other joints in the body is a pretty complicated area. There's a lot of mobility because we can put our arms behind us, over our head, we can write, we can do all sorts of motions. Think about all the things you can do with your shoulder that you can't do at your knee. However, there's always a trade-off, so the more motion you have, the less stability you have. So we have a highly mobile joint, but we have a less stable joint. In addition, our arm does a lot of things like overhead activity, and the more overhead activity we have and the more repetition of those activities that we do, the more susceptible the shoulder is to an overuse type of injury. So people like pitchers, throwers, swimmers, volleyball athletes, and then also if you think about your people that maybe work in a warehouse or have to put things overhead or reach for things, they can get shoulder injuries. So when we think about moving and stabilizing this joint, we need to think about the rotator cuff muscles. We have to think about the capsule and the scapula and how the scapula works with the shoulder. So let's start by talking about shoulder anatomy. So we have major bones involved in the shoulder are the scapulas. This is this big triangle-shaped bone in the back. You have your humerus, you have your clavicle, and we have ribs. And this is a front picture, so this would be the clavicle in the front. This is the scapula in the back, the humerus, and the ribs. So we're looking at some bony landmarks, and we have this jugular notch right here of the sternum. We have the sternoclavicular joint. That's where the sternum meets the clavicle. So the sternoclavicular joint, and there has to be a little bit of movement here. We have the whole length of this clavicle. We have the acromioclavicular joint. So this is where the acromion process from the scapula meets the clavicle. And we also have this coracoid process here. We have the pectoralis minor that comes over and attaches to this. This is the humeral head, the shaft of the humerus, and right out here we have the deltoid tuberosity. So the deltoid kind of comes across this whole thing and then inserts over to here. So those are the major bones and bony landmarks. When we think about the joints specifically, we have 4 joints. Remember, joints are where bones meet. Now, in order for our shoulder to do all the overhead motion, all these joints have to work together. So usually we think of the shoulder just as this glenohumeral joint, when in reality, to do all the motions, we're considering kind of the entire shoulder. So let's go back and review, even though I just went over some of them. So here's our sternum. Here's the clavicle. So this is the sternoclavicular joint. If you put your finger on this joint right now, you move your arm up and down into abduction and adduction, you should feel some slight movement at this joint because the clavicle has to elevate in order to get your arm overhead. Over here we have the acromioclavicular joint where the acromion of the scapula meets the clavicle. Now this joint should not move. If this joint gets injured, the acromioclavicular ligament gets injured, then we call that shoulder separation or AC joint sprain. We have the glenohumeral joints. This is when the humeral head sits into that glenoid cavity right here. And in the back, we have the scapulothoracic joint, where the scapula meets the thorax. Now, again, if you put your hand into a abduction-adduction motion or flexion-extension motion, you should be able to feel your scapula moving all around back there, because in order for us to get our humerus overhead, we have to turn the scapula and rotate it up so this is facing upward in order to get the humerus upward. So we have to have a lot of mobility with our scapular thoracic joint in order for our arm to work correctly. Here are our muscles. So if we start with the superficial muscles closest to the skin, our big kite muscle, again this would be on both sides, but we cut away on this side, is the trapezius. We have the deltoid, and the deltoid comes from the back of the scapula, so the spine of the scapula all the way over to the acromion, and here in the front to the clavicle, and it comes down and around and inserts into that tibial tuberosity. And in the back we have the latissimus dorsi, this big muscle down here that comes and inserts into the humerus over here. On the front side, superficially, we have the pectoralis major, so it comes from the clavicle, the sternum, and the ribs, and inserts over here into the medial portion of the humerus. Deep muscles, we have levator scapulae that comes from the scapula up to the occipital process up here. We have rhomboid minor and rhomboid major, which go from the spine over to the scapula. We have the supraspinatus, and we know it's the supraspinatus because it's above the spine of the scapula, above supra, spine, above the spine. We have the infraspinatus right here, this big one. It's below the spine of the scapula, infra, below. And then we have teres major, and we have teres minor. On the front side, we have our pectoralis minor, so this comes off of ribs 3 to 5 and inserts into that coracoid process. And we also have what's called the coracobrachialis, so it comes from that coracoid process and goes to the humerus. And if you think about muscles, they work by getting shorter, so if you take each of these landmarks and move them towards each other, that is the motion that muscle is going to do. We talk about rotator cuff when we talk about rotator cuff injuries. Our 4 rotator cuff muscles are going to be our supraspinatus, infraspinatus, teres minor, and then on the front side, oh, I forgot all about it. On the front side over here, we have the subscapularis. So the subscapularis comes from the back or the front side, the anterior portion of the scapula, and comes across into the head of the humerus over here. So this one does internal rotation. These 3 do external rotation. This one does abduction. And together we call those our rotator cuff muscles. So when we have a strain, it can be any one of these muscles. If we get cramping, it could be in any one of these muscles. We can also get trigger points or muscle tightness in any one of these, and that can cause improper motion in the movement of the arm. And we can also get tendinitis, where the tendons attach. Oh, we forgot this one too. This is the biceps brachii, and in the back we have the triceps brachii. Some other structures that are in the shoulder, we have a labrum. So just like we have that meniscus in the knee, we have this cartilage sitting in the glenohumeral cavity. So this is your glenohumeral cavity. That labrum is cartilage, and there's only one of them. In the knee we have 2, and we can tear those, and we call those labral tears when it tears. Sometimes when we tear it on top here, we would call that a superior labrum tear from anterior to posterior. And we call that a slap lesion. So that's another injury that you might hear. In addition, we have bursa. Just like we have many bursa in the knee, we have lots of bursa in the shoulder. So all these green bubbles are indicating bursa. So you can see you have one right here under the coracoid process. You have one here between these ligaments, one here under the acromion. When they get inflamed, they get swollen and take up space, and it can cause pinching and pain in the shoulder. So for the motions that our muscles do when we want to flex our arm, that's going to be our pectoralis major and our anterior deltoid with our biceps. Extension going towards the back, latissimus dorsi, teres major, triceps. Abduction going away from the body, supraspinatus and deltoid. Adduction, pectoralis major and your lats. Medial rotation or internal rotation, pectoralis major, subscapularis, latissimus dorsi, teres minor. Lateral rotation going away from the body, infraspinatus, teres minor. Horizontal adduction, deltoid and pectoralis major. Horizontal adduction, deltoid, latissimus dorsi. Here's why knowing our anatomy is important. When we know our anatomy, we can figure out which injuries are likely. So if someone is hurting on the front side of the anterior portion of their shoulder, then in my mind's eye, I picture these structures right here and think, okay, what muscles are right here? What tendons are right here? What bursa is right here? what bones are right here. And then that helps me decide what injury it might be. If their pain's more on the top, then I go through the same thing. What bone is up here? What ligament? And that's how I start to narrow down what the injury could be based on the location. I'm going to do a separate video for this where I kind of show you these motions just to review your memory in case you've forgotten from A&P. But I do want to mention this, that we have what's called a scapulohumeral rhythm. So for every 2 degrees of motion that we have at the humerus, so getting this from here up to here, every 2 degrees that we have for the humerus, the scapula has to move 1 degree. So you can see how this is kind of like normal. He has his arm by his side and the scapula is here. And if he wants to raise his arm overhead like this arm, this scapula has to move out. So for every 2 degrees of the humerus moving, we need the scapula to move 1 degree. And we call that normal scapulohumeral rhythm. And altogether, the scapular or the sternoclavicular, glenohumeral, and scapulothoracic joints should work together. If one of those has limited motion, then we have problems with our biomechanics of our shoulder movement. And those restricted range of motions can cause forces on other parts of our body, such as the neck or the shoulder, the low back. But also it causes the structures underneath those skin, those tendons, those bursas, to possibly become pinched, to have an overuse injury, to have tendonitis, and things like that. So we need to have correct motion in all those joints to have optimal performance and range of motion at the shoulder. To prevent shoulder injuries, the proper conditioning is the key. You want to make sure that you're developing the region specific to the sport. So activities that you would do with a baseball player may be different than a swimmer and should be different than a swimmer. When we're working on strengthening exercises that we want to work through an entire range of motion, we don't want just to have the elbow at the side for all of our activities. We want to do a lot of overhead activities as well, because when we do life and when we do sport, a lot of times our hand is overhead. We also want to put an emphasis on those rotator cuff muscles. So instead of just doing push-ups and bar press and hang cleans that are kind of in a straight or forward plane, we also want to make sure we're getting the full rotation through the rotator cuff muscles. And we can't forget about that scapula. So we want to do scapula stabilizing exercises because that is the basis support for the glenohumeral joint. We always want to make sure that we're doing warm-ups before any sort of explosive arm movement. For sports that involve contact and collision, football, wrestling, lacrosse, the athlete should receive proper instructions on falling, because you saw in that one video that we did with the football player who reached his arm out and fell, that is the most common mechanism for some of those shoulder or forearm injuries, is falling on an outstretched hand. Make sure the athlete is wearing correct protective equipment. We want to look at the mechanics when someone comes in with an overuse injury to see if their mechanics is off, and then also make sure they're getting proper throwing instructions to prevent injuries. When someone comes in with a shoulder injury, we always start by asking questions. Remember, we ask questions with the knee. So we want to say, what's the cause of the pain? How long has this been happening? Have you had a previous injury in this place? Can you point with one finger to where the pain is? Do you have crepitus? That's that kind of like crinkly feeling under your fingers. Is it weaker than the other side? What makes the pain go away? Have you done anything recently in your training changes? Once I do all that, I should be able to at least narrow it down to whether I think if it's a chronic injury or a acute injury. And have a good idea if I'm thinking about if the pain is on the inside of the shoulder, the anterior, posterior, or superior aspects of the shoulder. I also want to look at their arms before I do anything else. So I'm looking at the tips of the shoulder. Is one higher than the other? Are the clavicles aligned? Are the acromion processes aligned? Is there symmetry in their biceps? I want to look at their posture. Because if I'm trying to do overhead activities and they have this type of posture, or really this type of posture, then it's going to throw off those mechanics. This is how they should look for optimal performance. I'm going to look at their position of the scapula, if the scapula is sticking out or winging, and muscle symmetry. I'm also going to look for that scapulohumeral rhythm. Is the scapula moving as much as it needs to for that overhead palpation?